Good morning, everyone, and welcome to the Lunch and Learn developed by Community Campus Partnerships for Health. Today's topic is community-based participatory research, lessons learned, and local adaptations. Next slide, please.
Actually, let's have the Spanish interpreters.
Oh, I'm so sorry. Yes, Spanish interpreters, please take over.
Thank you very much, Alan, and good morning, everyone. My name is Sandra, and I am with my co-interpreter, Alejandra. We're going to be your Spanish interpreters for the day. And this session will also have American Sign Language interpretation available. So now we're going to give you some instructions to access interpretation on Zoom. If you need this feature, we recommend that everyone chooses their language so that if there's participation in Spanish, you're able to hear what the participants in Spanish say in your language of preference. So I'll give these instructions both in English and Spanish so that everyone can access the feature. I will start with Spanish first. Buenos días a todos, les damos la bienvenida a esta sesión. Mi nombre es Sandra y estoy con mi cointérprete Alejandra. Vamos a ser las intérpretes de español de esta sesión. Esta también va a tener interpretación en lengua de señas estadounidense. En un momento les voy a dar instrucciones para que puedan acceder a la función de interpretación de Zoom. Les recomendamos, por favor, que si desean escuchar la sesión en español, sigan estas instrucciones. Entonces, si están desde una computadora, en la parte inferior de su pantalla van a encontrar un icono de globo terráqueo. Hagan clic, por favor, en él y encontrarán una opción que dice Interpretación de idiomas o Language Interpretation. Y ahí encontrarán el canal de español. Seleccionen español y si no desean escuchar el audio de la sala, pueden elegir silenciar audio original. Si están conectados desde una computadora Chromebook o desde una línea telefónica, no podrán tener acceso a esta característica. Si están conectados desde un dispositivo móvil, pueden tocar ligeramente su pantalla y aparecerá un menú de 3 puntos con la palabra More o más. Ahí encontrarán otra vez el icono de globo con la opción Interpretación de idiomas o Language Interpretation. Una vez más, seleccionen español y elijan Done o Listo. También, si no desean escuchar el audio de la sala, pueden elegir silenciar audio original. Si tienen alguna duda respecto al uso de esta característica, pueden ponernos un mensaje en el chat. Ahora voy a dar estas mismas instrucciones en inglés. So if you want to access language interpretation, you will find, if you're on a computer, you will find a globe icon at the bottom of your screen. Please press that globe icon and go to the option Language Interpretation, then choose your channel, in this case, English. Please do not select mute original audio or you won't be able to hear the participants in the main room. If you're joining from a tablet or a phone, you can press your screen lightly and then choose the 3-dotted menu with the words More. Then you choose Language Interpretation and then your language and then press Done. Again, make sure to not mute original audio or you won't be able to hear the participants in English. Also, if you're joining from a Chromebook computer or a phone call, you won't have access to this feature. If you have any trouble accessing the interpreting feature on Zoom, please feel free to leave us a message in the chat. So we remind you to speak at a moderate pace, and then if you have any questions, you can contact us. So we'll go back to Alan now. Thank you very much.
Thank you. Next slide, please. Okay. Good morning, everyone. It's poll time. We'd like to know from the audience, how familiar are you with community-based participatory research and action research? So submit that and we'll get a read for the room, please. Thank you, Fatima.
Responses.
Okay, excellent. Thank you so much for Administrator Fatima, who I think a lot of you know. So let's see, about half and half, familiar, very familiar, and not at all, 13%. All right, thank you very much. So my objective here in the first 15 minutes or so in this session is to simply give us a quick background of CBPR, introduce our panelists from the Greensboro Health Disparities Collaborative, talk a little bit about CCPH, and then hopefully we can get like some good case examples of CBPR or community-based participatory research in action. A little bit about us. Community Campus Partnerships for Health promotes health equity and social justice through partnerships between communities and academic institutions, and we have a 25-year history of doing that. On the left is our Director Al Richmond, who many of you may know from the community groups in North Carolina. Next slide, please. The strategic pillars, the things that sort of frame our work would be leading and ranging from the Institute of Medicine, lots of NIH panels to local community panels, disseminating information and teaching very much like we're doing today, partnering and training, and actually facilitating partnerships and studying and learning about how partnerships work the best to get the best results to reach our goals. Next slide, please. As an icebreaker, in the chat, please, just put your names and pronouns if you're comfortable doing so, and tell us where you're from and what community groups you work with. Just a few quick seconds to do that in the chat. I know we have our panelists from the Greensboro Health Disparities Collaborative here, which I will introduce, and it's a broad variety of people. We have community activists, physicians, and academics representing the full spectrum of community-based work. I see lots of other lovely faces. Yvonne, oh yeah. In Chicago, awesome. Celeste, Suzanne Sanning, Central Iowa, wonderful. A lot of politics in Iowa this week. Christina, here we go. Lynn Newen from Houston. Chatham County, North Carolina. Brown University School of Public Health, Sarah, welcome. Awesome. Matt Manning, Dr. Manning is here. Skinner from WashU, Karen Skinner from WashU, awesome. Kathleen, Health Collective Harm Reduction, Kathleen, awesome. In Philadelphia, Ms. Parker from Philadelphia, thank you so much. Well, so we have people from all over the country. That's beautiful. Latoya, Westside Chicago. Excellent. Oh, we have someone from Greece, Germany, work with health and underserved communities. So let's moving on. Welcome everyone, and thank you so much for joining us today. Some key terms we're going to be going over here are, of course, community, community-based participatory research, health disparities, and social determinants of health. I'm going to go into some of these concepts in a little bit more detail for the introduction. Next slide, please. Okay, the learning outcomes for today. At the end of this session, we would love for our audience to discuss the contrast between traditional scientific research and participatory research. We'd like to review some of the lessons from the Greensboro Health Disparities Collaborative and action research in the field we can learn from that group. Taking it home, we'd like to list strategies that advance equity in your community through the mechanisms of action-based research and the collaborations that we're going to discuss with our distinguished panel today. Next slide, please. Okay, it's my great privilege to introduce our panel of experts, starting with Christina Young. Christina Young holds a master's in public health and has managed a NIH research study which eliminated a racial disparity in cancer care through community-based participatory research. She is currently the Director of Undergraduate Studies and an Associate Professor in the Department of Public Health Education at the University of North Carolina at Greensboro. She is the co-chair for the Stakeholder Advisory Board for the study called A Cure. This is accountability for cancer care through undoing racism and equity. And a Cure for Moms research study specifically. She is the mother of two talented daughters who make her a cheer mom and a piano mom. So she's a busy lady. Thank you so much for being here today, Christina. In the middle here is Dr. Matt Manning. Dr. Manning is a radiation oncologist from Greensboro. He earned a degree in chemistry from the College of William and Mary and completed medical school at VCU, Virginia Commonwealth University. He joined Cone Health in 2001, implementing advanced technologies such as IMRT, SRS, and SBRT. He has served as the medical director of stereotactic radiosurgery and the medical director of radiation oncology at Cone Health, and has also served as the chief of oncology. Dr. Manning is committed to successful community cancer research. In the past 3 years, he has co-authored over 20 articles published in academic journals. Dr. Manning's project has drastically reduced costs in oncology and received the ACCC Innovator Award, a project focused on hotspotters. He showed that costs are less driven by expensive cancer treatment and result from gaps in the coordination of services in medically complex patients. So Dr. Manning is a patient advocate and an accomplished and distinguished oncologist in the community. He is active in the hospital's next generation ACO, having served as the oncology division chief and operating committee member. Manning is also a member of the Greensboro Health Disparities Collaborative, who conducted A Cure, the study we just mentioned. He's board certified in clinical informatics and has served on the Epic Oncology and Radiation Oncology Steering Committees. He is the past president of the Greater Greensboro Society of Medicine and also served on the ASCO membership committee. Dr. Manning and his wife Allison have 3 daughters, and he loves dragging their suitcases through airports, playing music, and walking his dog. And last but certainly not least, we have a community activist, Rebecca Chandler, has been active in the Greensboro Health Disparities Collaborative since 2017. Rebecca is a cancer survivor herself, and while struggling to navigate the healthcare system, which seemed to be structured in a manner that empowered the system rather than the patient, she became active and remains so in the Greensboro Health Disparities Collaborative. She is now passionate about challenging systems to base their definition of value and success on the customer and patient perspective. So wow, thank you so much you all for joining us, and we look forward to hearing a lot more from you later. Next slide, please. Chat storm. In the chat, tell us an example of how you have been engaged in collective action for health improvement. Just a quick one-liner, getting to know you in the chat. How you have engaged in collective action for health improvement in your community. Just give that a few minutes and we'll read some of those off. We just talked about Rebecca. Lots of people from Chicago. Here we go, Celeste, thank you so much. Improving healthcare with the immigrant community, barbershop events in Wilmington. Barbershops are a great community focus for getting health information. Community and health kind of connections. Kieran, part of a multi-organizational collaborative for improving health in southeastern North Carolina. Jennifer, supporting FQHCs. Collective Action in Maternity Care Center by Corinda Roebuck. Beautiful. Lots of different examples here, and keep them coming. Community Project in Maywood, Chicago. Thank you so much. So let's just, as we're looking at scrolling through those, let's just review some key terms. What is community? Of course, this is a very general term. They often are defined by geographic proximity, background, circumstance, similar situations to address issues affecting well-being. And of course, one person can belong to many communities. That's why we have concepts such as intersectionality, where one person is engaged in so many different positions. But the community for the position of health studies typically means some kind of social cohesion that you can act together to define, address, and solve and sustain answers for a specific problem in the health sector. Next slide, please. Key terms that we mentioned: health disparities. We're working with Disparities Collaborative. This is preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Social determinants of health is an area of focus that are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. And that's a very general definition by the CDC. That's a working model for a lot of the work in community-based practice. Next slide, please. Community-based participatory research has a rich history. It is a collaborative research approach designed to ensure and establish structures for participation by communities affected by the issue being studied. Representatives of organizations and researchers in all aspects of the process. So as we see in our panel today, there is a spectrum of contact with the community-based approach. We'll go into this in more detail. And it's good to think about what do you think as traditional scientific research versus a community approach in research, and how that translation and that lift can be difficult and is actionable. Next slide, please. One good way to talk about this is the basic juxtaposition, if you will, of traditional scientific research and community-based participatory research, or CBPR. For example, in the arc of disparities, which we talk about a great deal, disparities research used to be simply a matter of documenting them. These disparities exist, and that was the end of the research. Then you move into how do you do actionable solutions. So this transfer of including people in the research process breaks the mold of traditional research in certain ways. In location, traditional research was an outside person looking in. Here in community, we have a team of stakeholders that represent the issue. Instead of experts defining what needs to be researched and how, we have collective ways of determining what needs to be researched and what needs to be addressed. An example today, in our very short time together, could be the complications of the system need to be illuminated from the within, not just from the outside. Findings may or may not be used to make changes in traditional research. It's just a matter of new knowledge generated. We have to have early buy-in from stakeholders that look at the impact in community-based research. Instead of experts interpreting findings and disseminating data to an academic community, we look towards community partners that disseminate data who are affected by the community. In fact, they might decide on the questions together. The capacity leaves with the expert, the ability to make changes, attempts to be made in the community itself. And the values lay both in academic knowledge and lay knowledge. We want to promote equitable partnership practices at every stage of the process. So in other words, researchers had a habit of helicoptering over a community kind of lifting down their claw, getting some data and rushing off. Community-based research looks for improvement that is sustainability. It looks at dissemination of knowledge and evaluation that is generated within the community itself. And to do this, you have to change the structures of traditional research indeed. And action research is the mechanism for doing that. Next slide, please. Okay, so I'm just going to do a quick model here for engaging communities in CBPR conceptual practices. And this is the logic model that helps many people. It's developed through the NIH Center at Engage for Equity at the University of New Mexico, and lots of tribal partnerships, native and universities in New Zealand also contributed for this. If we look at the beginning, what is the context of your community? What are the social, structural, and political aspects of the community that matter? What is the health issue of importance? We often talk about health studies in our work here together today. What is the capacity and readiness? How ready is the community? How organized is the community? What kinds of strengths and capital do you have on the ground? What kind of collaboration or trust do you have? Sometimes you'll go in to address an issue where the community just needs more time to coalesce, get to know each other, make decisions about what needs to be addressed. Next step in this is partnership processes. How do we look at the structures? Who are we working with? What are their relationships? Again, our panel today is a wonderful example. We have the community, we have academicians and practitioners. In this particular Health Disparities Collaborative, we have collaboration, we have work on breast cancer. So we have an oncologist, we have a community member and a survivor, and we have academicians and teachers like Christina. In moving to the intervention and research stage, we have to integrate community knowledge, that's the goal, and do culture-centered interventions. We have to look through partnership synergies and appropriate research design, and the outcomes should be substantive and ongoing. So we have sustained partnerships, we have shared power relationships and things like this. So we go through this flow for the long-term outcomes of community impact and transformation. A very quick and dirty look at CBPR, but I think a helpful model. So let's move to the next slide, please. We'd like to do a breakout exercise and work in groups before we break into our panel. So we are going to assign breakout groups to talk about the following. How has your community group come together to define and address health issues? Please share any lessons or challenges in your teams, and we're going to break out and do that and come back and go back to our panelists. Thank you very much for your time today. I look forward to participating and hearing your lessons. Thank you. Well, I'm so sad that's over because I was seeing all my friends. Everybody knows everybody. Deborah from Milwaukee said hello to like 5 people. People that do CBPR, it's a small world, y'all. I'm telling you, it's crazy. Okay, can everyone hear me okay? I'm just going to hand it over to our panelists. I'm so excited. My panel was fantastic. Our group was fantastic. We talked, everybody's doing built environment and public art in a research space, in the community means public space. And that's what we want to share out basically. But I'm going to hand it over to our distinguished panelists from the Greensboro Health Collaborative.
Yes, thank you so much. We're glad to be here. And I was going to get my thing up so I can keep track of time. I'm Christina Young, and as it was introduced before, I'm representing an academic voice, but also a community voice. And so I'll break that down. But I wanted to start off by telling you about our collaborative, and then I'm going to pass it to Dr. Matt Manning, and then I'm going to pass it to Rebecca Chandler. And so to let you know about our organization, we also will drop some links in the chat for you at different times during our talk. The Greensboro Health Disparities Collaborative started from community organizing. So neighborhood advocates, particularly within the African-American community in Greensboro, were organizing, and they were curious and passionate and committed to doing something differently to solve the racial health inequities that they saw were longstanding problems in our Greensboro community. And so it was both based on personal experience, but also the Institute of Medicine's Unequal Treatment Report that came out in 2002, which makes us 20 years old as an organization, just to let you know. But there's more about our background on our website. And so I'm going to give you a link to that where you can see some videos that we produced about our story. Part of our story is that we started organizing with academic members, community members. Again, this started from the community organizing, inviting academic partners, inviting medical partners to what was a coalition or an initiative. It started with an 18-month planning grant from what was the Cone Health Foundation. Many months of relationship building and learning about CBPR happened before we applied for our first NIH grant. All members of our Greensboro Health Disparities Collaborative were required to attend what's called the Undoing Racism training by the People's Institute for Survival and Beyond, and also the Racial Equity training, which is also offered here through the Racial Equity Institute. I'm going to slow down just a bit. Through the training, we learned the definition of racism. And so in that definition, we learned that it was racial prejudice plus institutional power. So we had to analyze what is power, who are the decision makers, and how does that influence institutional racism? Because there were these long-standing health disparities in communities, but nothing had been done to change them dramatically, because a lot of focus had been, as Alan Wells was talking about, on just identifying what the disparities were. And so we had to first learn, how was the institute involved in this, the institution. So there are many diverse members of our Greensboro Health Disparities Collaborative. And so I'm going to share a link with you of all of our members. We're listed on our website. We went through CBPR training. And so the first research study was an exploratory study. So it took 18 months. So just want to make that clear that this takes time to build relationship, make these things operational. And our exploratory research study was called CCARE's Cancer Care and Racial Equity Study. And this is when I joined the collaborative. I joined as the first project coordinator for this exploratory study. And it was after my own mother passed of breast cancer. And so I came in from a lived experience of losing my Black mother to breast cancer, but also from my background in public health and wanting to work on this from a professional angle. But I was employed with the academic partner. This was a $206,000 NIH grant. As we learned in that experience, what were the differences that Black and white women had with their experience and journey through cancer? We decided we need to do something about that. And so this is when the collaborative took more time to submit another grant. This is the ACCURE study. And that stands for Accountability for Cancer Care Through Undoing Racism and Equity. And this is a 5-year project, and it was $2.5 million granted to our Greensboro Health Disparities Collaborative from the National Cancer Institute. I was the project manager for that study, and we had 2 sites. We had one in Greensboro with Cone Health, and then we had one in Pittsburgh with the University of Pittsburgh's Medical Center. So we were comparing breast and lung cancer patients and to the journey that they had through the institution. We also partnered with Sisters Network, which is a survivorship organization for African-American women, and they have a local chapter in Greensboro. We were responsible for helping to start that. Some of our members of the Greensboro Health Disparities Collaborative were. And by talking with them, it helped us to learn how to recruit Black patients into a clinical trial, because there's a lot of mistrust from clinical research. I'm going to stop there and pass it over to Dr. Matt Manning, who'll tell you more details about the ACCURE study.
Yeah, thanks, Christina. So I'm Matt Manning. I'm a radiation oncologist by training, and I was a little embarrassed about how long my bio was there, but I was not here in the beginning of the Greensboro Health Disparities Collaborative, but when we got to this ACURE study, that was an R01 sponsored grant, and the study was launched at Cone Health, there were opportunities for physicians to serve as leaders with the trial to help engender the trust of physicians and nurses and healthcare team members. And so I became a physician champion for the ACURE study, helping to provide feedback to our lung cancer team. And essentially, what we knew going into the ACURE study is that Black and white patients with curable lung cancer and breast cancer, Black patients complete treatment less often than their white counterparts, contributing to worse survival. So in implementing a solution to that, the ACURE was an intervention trial designed to address the problem. And it was a pragmatic quality improvement trial. It was active from 2013 through 2015, and the enrolled patients were compared to historic patients as well as contemporaneous patients. And it was available to patients with early stage breast cancer, early stage lung cancer, enrolled Black and white patients. In the historic group, and the intervention included a few elements. One was what we called a real-time registry, which was derived from electronic health records, which helped signal the healthcare team when patients missed appointments or they had unmet milestones in care. For example, if you were diagnosed with early stage lung cancer, you probably should have surgery or radiation within 6 weeks. If 6 weeks elapsed and they weren't addressed, then that would trigger our team to reach out to patients and try to eliminate that issue. And we also had a nurse navigator who was trained to address some of these barriers that patients encounter. And there was also clinical feedback to the providers and the whole team about these disparities using our own data. Like most physicians, when this concept was introduced to me, I said, well, I treat everybody the same, and I don't treat people differently based on their race. And that's maybe true, maybe not true, but there are also so many other institutional barriers in place that if I don't make extra efforts for different populations, then there might be disparities in outcomes. And so at the beginning of the trial, Black patients completed treatment 79.8% of the time, while white patients completed treatment 87.3% of the time. So about a 9% difference. And with the intervention, Black patients completed treatment now 88% of the time, white patients 89% of the time. And so what the ACURE study did was it eliminated racial disparity in completion of care, but it improved completion rates for both Black and white patients. So it wasn't at the cost of reducing outcomes for white patients. And it was groundbreaking in that if you look at health disparities and you search for that on PubMed, you'll find thousands and thousands of articles. And almost all of them are just characterizing health disparities and describing them and describing the hypothetical reasons for them. This was one of the first publications that described it and then eliminated it. And I think that is the foundation of community-based participatory research, because the solution came from feedback from the communities we were going to serve through the CBPR process. And I'll turn it over to Rebecca to talk a little bit about how the community provides this input and how important it really is.
Hi, I'm Rebecca Chandler. As you heard in my bio, I'm a member of the Greensboro Health Disparities Collaborative, and I'm also a breast cancer survivor. I actually joined the GHDC, as we call it, after the ACURE study was completed. And by complete random, I happened to learn about GHDC. I was going through treatment. I went for a scan and popped into the cafe next door for lunch, and struck up a conversation with the people at the next table about the menu, and lo and behold, one of them was our co-chair, Carrie Thatcher, who informed me about the Greensboro health disparities. And at that time, I didn't even know what the word disparity meant, but Carrie explained it to me, and I really resonated with it because I had had such a tough time navigating the system myself, with some alternative beliefs and just some aspects of my personality and being a member of an alternative religion and spiritual beliefs and things like that. And so I felt that if it were that difficult for me as a white woman to navigate the system, then imagine what it must be like for other racial groups to navigate the system. And so that's why I got involved in the GHDC and, you know, am passionate about helping to resolve health disparities now. You know, I can, if anyone's interested, I can speak more, you know, now or at a later time about some of the very specific issues that I experienced going through the system. You know, but like I said, you know, everything from being an introvert and feeling like, you know, I'm coming in and I'm meeting all of these caregiver or providers at once, everything from the intake people to the nurses to the doctors to the, you know, all of the staff, and everyone is bombarding me with questions at the same time that I'm trying to deal with what is a life-changing diagnosis and treatment plan. And so I just really shut down. And also at the same time, I didn't feel that some of my spiritual beliefs were being taken into account. And so how this relates to CBPR is, you know, I really just felt like the system had a plan for me, and they were going to fix me. And, you know, as admirable as that is, you know, I wanted to be the primary stakeholder in my medical care. And I felt like you know, I felt that that was not the case. And so that's, you know, why I'm so passionate about getting the community involved in their healthcare. But what was really interesting was, you know, by the end of my journey, I ended up, you know, connecting with some providers who were very interested in understanding my beliefs and my personality, and also but also bringing their medical knowledge into it. And so, but they were so understanding of me that we were able to develop trust. And that was just, I can't emphasize enough how pivotal that was in me completing treatment. And I'm so sorry. It's so obvious to me as my story, but I'm forgetting to mention that I actually refused treatment at first. The situation was so overwhelming and upsetting to me that I actually left the cancer center and decided I was not going to receive treatment. I was just going to receive naturopathic and herbalism and things like that. But of course, that didn't solve my problem. And as things continued to get worse, I ended up going back and seeking treatment, but more on my terms. And so then at that point, I was able to connect in with an oncologist, just a very special oncologist with an excellent bedside manner, and a chaplain and a nurse navigator, and some different people who really helped understand me and what my belief system was, and to try to balance that with their understanding of the medical side of things and the scientific side of things, and what my options were, to just, you know, very much try to meet me in the middle and help me explore options, but also understand when it was time, you know, to say, okay, perhaps that didn't work and now we have to move on to, you know, a more strenuous treatment regimen. But the point in all of that is that what was so pivotal was being able to develop trust before we actually started, you know, putting things into my body. And so that was just very important to me. So yeah, at this point, I'm not sure who I turn it over to next, but you know, just very grateful to have found the right team. And now I'm 5 years out, and am very passionate about trying to help other community members and be involved in GHDC.
Wonderful. Thank you so much, Rebecca. So I'm going to turn to our timekeeper and say, do we have any more comments from GHDC? Just some closing comments for the session today. We have a little bit more time.
I'll just say some of the challenges and friction. There are issues that arise when the community partners with academic organizations and with healthcare companies. And some of those frictions involve the acceptance of qualitative research, the acceptance of how patients feel with certain interactions as opposed to hard data. And that can be a challenging issue to learn how to communicate with one another and really see the value in qualitative feedback. And then another challenge has been sort of claiming credit once everything does look good or once a project is done, that who's going to tell that story and who's going to own those successful results. Sometimes the bigger academic institution or the healthcare system will want to say, oh gosh, look what we've done, when really it was the community that was responsible for it. But the community may not have a marketing department and a social media team, and that can lead to some friction that was maybe unanticipated.
Absolutely. I mean, thank you, Dr. Manning. Putting the community forward is a great idea, but how do you do it? And here we have at Greensboro a good working example. Even in my group, we had examples of how something like including community members in publications, including community members in dissemination of the information, making people feel like they're not being talked about, but they're talking with, making people feel as if they're not part of the problem, but people are part of the solution. And a lot of these structures in academics are starting to change very slowly. It's like a glacier. So what are some take-home points from your lessons, Christina, Matt, and Rebecca, from working on this coalition that you would give to others in the group today who are working in community? How would you just like segue and say, hey, here's some, and the first lesson Dr. Manning has just said is, yes, we have to look at data differently. We have to look at credit differently. We have to look at people's voices and disseminating that voice differently, and systems, all of that good stuff. So give us some take-home points, y'all, because you're awesome.
Thank you. Yeah, I was going to say, and the way that Rebecca explained it is perfect, that when you join a group, ask a lot of questions. So as she was describing her story through her journey, asking questions while you're in the treatment journey, but then as you're talking about partnerships, so since I was in a middle space of being a project manager, it was very important to pull the voices out. So making sure that there were time for questions, time for people to maybe slow down Dr. Manning and what he's talking about and ask some questions. Well, what do you mean by this kind of appointment? What do you mean? And then asking the questions of the academic researchers also. Why are we going to measure that? And all of those things. So one of the challenges sometimes is that academic partners will have a plan. Like, this is the way we plan to do this project, and we think it's going to be great. And then when we bring it before community members and there's a lot of questions, and then there's another suggestion of, no, you need to do it differently. Because if I heard the same thing that you're talking about, I would not join the study. So that makes us change what we're doing, and it makes it more effective. And so even with what Matt Manning was saying, it's you, and the way you were positioning it also, the difference between traditional and community-based participatory research, it forces you to slow down. It forces you to revisit and change your plans. And so it takes humility to do that. And so I would just take away as for those who are in the academic space or maybe in the medical space, to realize the humility that's required in the work.
Absolutely. Take your time. All of the assumptions we make about partnerships being created are often wrong. It does take time, it takes space, and it takes attention to developing your relationships. Anyone else in closing, because we need to move on for sake of time? It's been so helpful today and beautiful for everyone. We are just going to continue with like good people, researchers and everyone. We do have an evaluation. We'd like you to fill it out. We're going to pause for 2 minutes to do this short evaluation if you are willing to help us out with that. And thanks, my panelists. Thanks, panelists, so much for your participation today. It's been wonderful and awesome. It's great seeing everybody out. thereof. And we're going to break for evaluation. Thank you.
Let's just move forward with a thank you and the save the date, Alan.
Okay, so thank you very much. You can visit our website at CCPH for more information about us on Facebook and LinkedIn. We'd love to help you and learn about you. Save the date. We have more of these lessons coming up in August: culturally responsive dissemination and community advisory boards, getting down. And we would love your experience, strength, and hope, and all of these things. If you want to chip in, CCPH is trying to initiate the national conversation so that we give good tools and networking for people doing community work. Next slide, please.
That's the last slide.
Oh, that's the last slide. Okay. So I have about 2 minutes left if you would like to break for evaluation. Could we put the evaluation slide up again, or they have the link? Awesome. Well, we're going to sign off with that, and thanks everyone for their time today, and have a wonderful afternoon.